Well, good morning, everyone. Thank you for putting the time aside on a Saturday to come to our annual CF Education Day. This is our 13th annual Education Day, which takes a lot of work, but we do it with great pride and putting a lot of love into it. And I want to thank once again Colleen Dunn, who takes the geoman's work of putting this on her shoulder and carrying the ball to goal every year. So, Colleen, where are you? She's busy getting people in, I guess. I also want to thank once again this year CFRI. They're making us very popular on the web. We're live webcasting this event so that people that cannot come for different reasons and people that are in different parts of the US or the world can enjoy the meeting. And without any further ado, I'd like to introduce our featured speaker, Steve Rowe from the University of Alabama. I don't think needs much of an introduction. He's a well-recognized name now within the CF field. No one better than him, truly, to give us up to date on where we are with our new treatment paradigms for CF. Steve?
Thank you, Carlos. I'm really happy to be here to share this day with you. From all accounts, I know this is a very motivated and interested group of families and patients at the center, and I'm really happy to kind of share that day with you. I am from Birmingham, Alabama, and you might have heard us on the news when about a year ago this tornado passed through Tuscaloosa and Birmingham. This was a picture from our CF center, really about just outside from our office, where you could see that major tornado going through North Birmingham. Some liken the damage to that of a war zone, but in CF, this is our war zone. This is the airway epithelial surface, in which you can see there beating very vigorously, about 20 times per second, is the cilia that function to keep our airways nearly sterile below the first third or fourth division of our lungs. And it's that process that we're targeting to try and fix in CF. But we stand on very firm ground as we think about making major advances in CF, and that is that there's been a significant improvement in survival over time, and you can see this broken down into five-year breaks, where we've made a substantial improvement in the median predicted survival. And I think what we'll see in the coming years is that this pace of improvement will improve even greater, and will also make significant improvements in the lives and the livelihoods of patients with CF. In part, that's due to a vigorous pipeline of research and therapies that have reached and become available to CF patients. It's really the massive improvements in supportive care that these improvements that we've seen so far can be attributed to things that such as treatments that CF patients use on a daily basis, such as pulmozyme or hypertonic saline or azithromycin or inhaled antibiotics. Those are very much responsible for the improvements, and you can see from this pipeline, which many of you I'm sure are familiar with, that there are many other treatments across the different disorders that cause CF that are on the way. It's from a firm understanding of the pathophysiology of CF that we think about the next era of therapeutics, and it's the area that I've been most interested in our group, and that I hope to share a bit of with you today. We know that CF starts with the abnormal gene, and at the end of the day, it initiates a cycle of destruction that includes mucus obstruction, infection, inflammation, and scarring that causes the lung disease to progress. And it's the steps in between that are still actively being researched. But this is one important model that shows that the abnormal CF protein results in a defective ion transport environment that alters the epithelial surface, so the surface of our airways, that makes the mucus abnormal, makes it more difficult to transport, in part because of fluid depletion of the airway surface that initiates that cycle. As we think about intervening, again, we think about the target being this chloride and bicarbonate channel that sits on the airway epithelial surface. Here you can see one pictogram as you zoom in to the smallest airways, where in these ciliated cells that we saw in that first video, CFTR is expressed and transports chloride and bicarbonate. And now from structural work, even though we don't know the precise structure of CFTR, we can understanding a bit more about how this protein works. Here you can see on the left side of the slide its predicted three-dimensional structure based on related proteins that have been effectively crystallized. And it has a number of important parts, but it's also unique in some ways. The green parts is that what sits in the plasma membrane, or the surface of the cell, and it forms the pore. And the areas in magenta and pink below it function to regulate that pore and open and close it in a very tightly regulated way. And you can see another model on the right of that CFTR protein opening and closing. The area in green is really the top part of that black and white diagram, and you can see that here, I believe. And then below are the magenta. And what they're doing is coming together and conferring a twist on that channel. And what you can see in the video that's below is that channel is opening and closing each time that twisting motion occurs. And that's what we call gating of the CFTR channel, as it opens and closes and functions to move the ions of the salt, if you will, that are made up of chloride and bicarbonate. And we also have a great deal more understanding about the cell biology of CFTR. And this video is going to take you a bit through that process. We know that when CFTR is made by the cell, it's made by a protein machine called the ribosome. And it's actively inserted into the plasma membrane, to the membranes that form our cells, and then migrates from the inner part of the cell out to the surface where it does its job. And so what we're going to see in this video is exactly that: a CFTR being made by a ribosome, inserting into the membrane, and then migrating its way to the surface, then where you'll see it gate and function to move chloride. So let's try and start that. Again, here you see the ribosome, and it's making the protein, and it's really being inserted to the membrane at the same time. And you can also see it's coming up and becoming folded at the same time. They accumulate in the inner surface of our cells and then pop out in these vesicles that then transport across the cell surface and make their way to the surface, where you can see they're inserting now. And if we were to zoom in on that insertion point, we'd see the CFTR channel, which I've shown you before, and there it is gating and functioning to move the chloride and bicarbonate ions that bathe our epithelial surface. Well, why is that important? Well, one important thing that we can see is that when CFTR is present and when CFTR is working to move these ions and move the salt and move the fluid, you get a more hydrated epithelial surface or airway surface. And what you see here is a new laser imaging technique which shows in cross-section cells. At the bottom of the screen are the surface of the cells. And what I think, certainly those of you that are in the front of the room can see, there's this vibration going on in this darker layer. And that vibration is the cilia that we've seen before, and they're functioning to vibrate and move remarkably the mucus that you can see on top of that vibrating layer from left to right across the screen. And that's what's happening in our airways, to move out bacteria and to move out mucus and keep the lungs clean. And you can see in a patient who was homozygous for the F508 mutation, their cells don't function as well. And you can see, I think, that the airway surface liquid layer, that mucus layer that's on top, is stuck down, and it's also depleted in terms of its amount. And it's that defect which we think is very, very important in initiating and making the pathogenesis progress in CF. Here's an example where we can see something very similar in tissues, in this case from a pig that has CF. And in a normal situation, you can see the mucus moving by very quickly, like you'd expect it to need to do to clear out the bacteria and the particles that we inhale on an everyday basis. Whereas on the right side in the CF airway, you can see that really simply doesn't happen. And I think I would be remiss to note that there's been significant advances really in the last 2 years, only the last 2 years, that suggest there may even be more to the story. And one thing that's being thrown around is a term called mucoviscidosis, which is an old term. It's one of the original terms that have been used to describe CF. And it means, obviously, there's something wrong with the mucus. And I think many patients and families certainly can relate to the fact that maybe the mucus isn't quite normal. In this theory that's really being advanced, and we don't yet know if it's important on the surface, but there's certainly reason to believe that it might, that it's the presence of the bicarbonate, which is a really important buffer, which again is moved by the CFTR, that allows the mucus to be normal. You can see on the top part of this slide, in the normal situation, when bicarbonate's present because of CFTR's working, the mucus is able to expand out normally. Whereas in the bottom, when bicarbonate's not present, the mucus becomes highly compacted and perhaps even stickier or more adhesive. And that could be an important part of the CF problem, perhaps in combination or on top of that liquid depletion, all functioning to, again, to slow mucus transport and make that function worse. And there's other work that's generated a fair amount of excitement among scientists, is that the abnormally bicarbonate also changes the pH of the airway. And the body does a lot to regulate our pH environment. And what these investigators found is that when the pH is abnormal, that airway surface fluid doesn't kill bacteria as well. And so there's yet another reason potentially that CF is having an onset and progression in people with CF. The abnormal mucus, the abnormal ability to kill bacteria, as well as its delayed transport. Well, we know that the end, regardless of the various contributions of these new pathways as they're being discovered and advanced and understood in people, that the end result is this thick inspissated mucus. You can see that on this scanning electron micrograph in a model of the CF airway, where you can see these thick plaques of mucus just coating the airway surface. But you can see over on the right that underneath there are the cilia, and they're in a position to do their job if only those thick plaques of mucus could be removed, and the appropriate content of the fluid around the cilia could be returned. And we also know that the glands also are a significant tributary. Here you can see, again in this model of the CF airway, this thick inspissated mucus being extruded from a gland, or the hole that you see in the middle of the screen, and plastering the surface with this thick mucus layer. So the next slide I'm going to show you is just a reminder in a video that some of you may be familiar with or have even seen before, but remind you as a summary of what we've talked about so far of our current understanding of what's going on in the CF airway. Some of you may have had to have, if you're a CF patient, may have had to have a bronchoscopy, or have had a loved one that had to have a bronchoscopy to understand more about what's going on with your loved one. This is an image. This is really a video that's meant to resemble what it would be like if you were a physician running a bronchoscope and looking down into the airway. So we're going to see the camera fly in like the bronchoscope would fly in, past the vocal cords, into the trachea and into the airways, and then with a bit of video magic, we'll zoom in on those CFTR channels and what they're doing to the cilia and the ion transport environment. So I'll start this now. Again, here we go in to the mouth and below the tongue, and that now we're passing through the vocal cords. And here's the trachea. Those rings you see are the cartilage that make the trachea strong. Now we're passing into the lung, and we're going to zoom in with that magic I promised and see these cells. And there are cilia beating in a very coordinated fashion and moving that mucus layer that's in yellow above that. And they're functioning because they're in that liquid-like gel that's working well. And here's CFTR, similar, moving that chloride and bicarbonate that's allowing the salt to move and therefore the fluid to move, to keep that fluid content correct in both its volume and its character. But in the CF situation, we see a CFTR channel that's locked shut. It's present on the surface, but the chloride and bicarbonate aren't moving. It's like a channel that's locked shut. And that, of course, is not normal. And that's what some CF patients have. And you can see the fluid then depletes, and then mucus tends to accumulate as bacterial infection starts. The body's response to that is to make more bacteria, which only worsens the problem. And then these large plaques form that simply do not move. And so that's really kind of a summary of what I've shown you till now about how many scientists think about the onset and progression of the CF problem, and therefore have driven many of the therapeutic approaches to stop these early parts of the disease. As we think about therapeutic approaches, this is a slide that's been frequently used to break this the different treatment opportunities into major categories. And on the right side, you see the most extreme form of therapy, and that would be lung transplantation, which sometimes needs to be done for some. And on the left would be ways to ameliorate CF by attacking the very fundamental problem, such as replacing the gene. Addressing the basic defect has another approach that's similar to replacing the gene, which is to use drugs that turn CFTR back on or bring more CFTR channels to the surface, depending on the nature of the problem. And we'll take a look about those type of therapies and where they stand with much of the rest of the talk. But it would be remiss to say that, again, to remind you that many of the advances that have resulted in improvement in the lives of CF patients and improvement in the life expectancy of CF patients have been treatments to address the abnormal ion transport environment or the mucus secretion problem. And these could be therapies like pulmozyme and hypertonic saline, or to address the infection and inflammation and tissue destruction. And these would be therapies that CF patients use every day, such as azithromycin or large high-dose ibuprofen and inhaled antibiotics such as Toby and Casein and others. So again, much of the rest of the talk is going to be talking about what's being advanced in terms of rescue of the CFTR protein. Well, to understand how we might rescue the CFTR protein, you need to have a firm understanding of the molecular pathogenesis of CF and how we might intervene to correct the abnormal protein. And what's been done is to break up CFTR mutations into major categories and then develop therapies based on those categories. One common form of CF is caused by class 1 mutations, which is caused by premature termination codons or nonsense mutations or other mutations such as insertions and deletions that cause major disruptions of the CFTR gene. And that's what's called class 1 mutations, where little or no CFTR protein makes it to the surface. And you can see the X at the bottom of the screen where the nucleus is, where CFTR channels are first being made. Class 2 mutations include the most common mutation, the delta F508 mutation or F508 del. These channels are misfolded in the cell, recognized as being misfolded and degraded in a compartment called the proteasome before they ever reach their active site at the cell surface, before they're able to even think about doing their job. There are other mutations that reach the cell surface but are defective for various reasons. That includes the class 3 mutations, which are like a channel that's locked shut. They're there at the surface, but that engine that we showed on some of the videos that functions to move those CFTR channels open and closed, that engine is completely broken. The channel does not gate, and therefore it doesn't move the chloride and bicarbonate and thus the salt. There are other mutations such as class 4 mutations. This would include the common R117H mutation, but many others. That the channel, the CFTR channel gates okay, but the channel is partially obstructed so that chloride and bicarbonate doesn't flow through the channel as fast as it should. And then there are other more rare mutations, but important ones, including class 5 mutations, where the protein is made wrong because of a splicing defect, or where the CFTR channel doesn't reside at the cell surface very long. The CFTR channel needs a signal to stay on the surface, and when that's broken, you get a class 6 mutation where it simply doesn't live on the surface for very long. And we now know that there's therapeutic approaches being advanced that could cover many of the CFTR mutation groups that we've shown. For instance, nonsense mutations, one form of class 1 mutations, can be addressed with agents that cause translational read-through or cause the cell to ignore an abnormal stop sign. We'll talk about each of these in a bit greater detail. Another group is called the F5-oidal processing correctors, or just correctors for short. This includes the agent VX809 that's been in study and causes the CFTR protein to fold up more correctly and therefore migrate through the cell and reach its active site at the cell surface. And there are agents called CFTR potentiators that function to activate or potentiate the channel and allow it to function more normally. And those are really being advanced mostly for mutations that are at the cell surface but don't function to gate normally. This agent really includes the agent VX770 or ivacaftor, which really accelerates gating. It accelerates that opening and closing motion we've seen, and it has now been shown to be effective in patients with the very common class, or the most common class 3 mutation, G551D. But it's now being studied in these other groups of surface localized CFTR channels. So we're going to take a closer look at the progress that's being made with CFTR potentiators and efforts to address the G551D mutation. So here we're going to see a video of that channel that's locked shut, and then what a drug like a CFTR potentiator, like ivacaftor, would do to that channel. So again, here's the channel, and it's locked shut. You can see the chloride and bicarbonate doesn't move. And then when the drug comes in and binds CFTR, which we now think that it does, you can see the gating starts, and then the chloride bicarbonate starts to move. And again, you can imagine that would allow that fluid to become more normal and the mucus to begin to transport. And we know that when in phase 3 testing, that allowed ivacaftor to be approved for patients with the G551D mutation who are 6 and above, that there was really a very large improvements in lung function that was surprisingly rapid. You can see it was observed here at the earliest time point, the 2-week time point in this study, and the magnitude of that benefit compares very favorably with other therapies that are now being used commonly for CF patients. And what we've seen is a very rapid uptake of this drug among patients with the G551D mutation. And like other treatments, we've seen a significant improvement in the frequency of pulmonary exacerbation, certainly an important marker for what we'd expect a drug to do. And it was accompanied with a remarkable improvement in sweat chloride. The sweat chloride improvement, as you can see here, was about 48 milliequivalents. We now know in post-approval studies that many centers are participating in, including Stanford, that improvement in sweat chloride was recapitulated exactly to the T, within a milliequivalent of that estimate. And what this is important because the sweat chloride test is one of our cardinal markers for how well CFTR is working that we can measure in people. And in fact, when you drop a sweat chloride by this much, the average sweat chloride in patients in this study was below the traditional diagnostic range of CF. And while we don't claim that these patients are normal or that their CF is cured, that would certainly be overstating the case. It's certainly important that their CFTR function is down into the subdiagnostic range and conferring those improvements that we've seen in lung function and exacerbations among a number of other markers. The way this is a model of how some scientists are thinking about using this case as a roadmap for what needs to be done next to bring these type of CFTR-directed therapies to many more patients. On the left side, you can see the CF in its most severe form, or what we call pancreatic insufficient CF. CF so bad that you need to take pancreatic enzymes on a daily basis. On the right side, is a non-CF, or essentially normal individuals. You can see right next to them are carriers. And if you look at the sweat chloride test, it's not a perfect line, but it's this curved line that you can see where sweat chloride really drops quickly on the left side as even small amounts of CFTR function confer improvements in those phenotypes. And we can use the evidence from the ivacaftor studies in patients with G551D to begin to get a sense for how well we need to do, how much function needs to be obtained in both the laboratory and the clinic to result in an improvement that patients and families would be happy with. For instance, we know from earlier testing of ivacaftor that the various doses that were tested land pretty much on this line when we measure CFTR function with a couple of different ways, either sweat chloride testing or nasal potential difference testing. And we also know that it was these moderate doses and greater that resulted in improvement in lung function. And so that gives us kind of some zones of interest where we can expect improvements to be seen, certainly in early phase testing, which is generally small groups of people, say 10, 20, or 30 individuals, to know if a drug is safe and can be moved forward. And so for this, in this example, and certainly there's debate exactly where these cutoffs go, but just using this as a representative example, you can see that we think we have to get about 30% CFTR function to really make a huge difference in the way patients live. And yet, if we don't accomplish that, but are still able to confer, say, 10% or 15% or 20% improvement, that we should still expect to see some measure of improvement among CF patients. And that's one marker that's being used to help drive science and know how well we need to be. We can envision what it would be like if CFTR function were returned in this way. And again, in this video, we'll see what would happen to the surface if CFTR comes back, moves salt and chloride and bicarbonate, and allows the mucus to break up and move. And so in this quick video, we'll see, again, that surface liquid starting to be reassembled, and the cilia then allowing themselves to beat and then begin to clear out the mucus and have a more normal situation. And that's what we think happened with the administration of ivacaftor to patients with the G551D mutation, and allowed the lung function then to improve in that way. Well, certainly, while that's a successful vignette, it's certainly not enough. That's only 4 to 5% of CF patients worldwide, and now there's considerable effort to advance these type of strategies to more CF patients. So while it's a remarkable advance, it's also a reminder of the challenge ahead. And the initial steps to try and expand the number of patients that could benefit from a drug like this are relatively straightforward. Here you can see a grid on the bottom of the slide just reminding us that 4% is not enough. But what's being done now is to first take the patients that are below 6 and study the same drug in the same mutation groups and look to see if it's advanced there. And that would add, we think, about 0.5% of more of the population. There's also a very closely related to the G551D mutation, a group of very rare mutations that make up about 1% of the CF population, where we think ivacaftor works very, very similarly and equally as well. And so those patients are now being enrolled in a study to look at the group of gating mutations, not just the G551D mutation. And many centers are enrolling in that trial. Well, what about other mutations? So if you look at this slide, we've talked about the one that's on the surface and far left that's noted by class 3. But there's good evidence now in the laboratory that CFTR potentiators, by stepping on the accelerator of gating, could overcome problems that aren't necessarily related to gating. Because the CFTR channel, when it gates, it's not gating at full speed. So if you could take that CFTR channel and take it to full speed, maybe you could make up for the fact that it doesn't move chloride and bicarbonate as efficiently otherwise. And that's the strategy that's now being tested in patients with class 4 mutations, or the R117H mutation. So what does that look like? Returning to these videos that hopefully reinforce what I'm saying and let you visualize it. Here's a channel that's moving some chloride. You see some of the chlorides moving through, but essentially gating can be put on overdrive and make up for the fact that the chloride movement is relatively slow. And what you can see hopefully is that the gating is about twice normal speed because the accelerator that's posed by a CFTR potentiator is being employed. So this is now being studied in yet another study that's specifically enrolling patients with the R117H mutation. And that was chosen because it's the most common class 4 mutation, and that's now enrolling in many sites across the country, but not just in the U.S., but in Europe and Australia, to answer the question whether or not these other groups of mutations can also benefit. And if successful, we begin to start to see that we're making a little bit bigger dent in the number of patients that could be eligible for a CFTR potentiator. Well, another approach is to try and abandon this mutation by mutation by mutation strategy and group people based on how they're doing instead of what mutation they have. At some point, certain mutations are so rare we can't imagine doing large studies to really understand how a drug might work in these rare mutations. Your families might be among those groups. So another way to do this is to group patients by how well they're doing and hopefully attack larger groups of people. One way to do that is to take the patients that generally have a milder form of CF, because if you have a more mild form of CF, you can infer that many of those patients will have a CFTR channel that's present at the surface and working, but just not working as well as normal. And so again, by stepping on the accelerator of gating, you could make up for whatever abnormality that is. And so that's a strategy that's being looked at in a study that's called an N of 1 study that takes a patient, makes sure that they're in that group of individuals that has partial CFTR function, and then applying ivacaftor. And that's a much smaller study that's being done at the University of Colorado in Denver. But again, the basis of this is that many of the mutations on the right side of the screen have partial activity, shown by the bar graph. You can see the mutations are listed on the bottom, and the CFTR function is listed on the y-axis, and the ones that are on the right are the mutations that have partial activity to begin with. Those patients generally have a more mild form of the CF, although that rule isn't absolute. And we know that the more function that mutation had to begin with, then the more that stepping on the accelerator of gating benefits that mutation. And so that's the strategy that's being used to enroll these individuals. So what about mutations that aren't at the surface that have other problems? Well, this is actually how I got my start in the CF business, a research business that is, and we're thinking about treatments that cause the translational read-through or premature stop codons to be ignored to allow a protein to reach the cell surface. That's been a strategy that's been employed, for instance, by PTC Therapeutics for the agent Adalurin, or formerly known as PTC124. I'll show a video of what this strategy looks like. This time, we're zooming in on the protein machinery that we saw in one of the first videos I showed, where we see the ribosome functioning to translate the message that your genes make. You see that strand that's running from the top left to the bottom right of the screen is the message that encodes our genetic code. And the machine of the ribosome that we saw before is there like a bead on the strand. And it's going to function to make the CFTR protein. Here, again, it's moving along the strand, and you can see that CFTR protein's being built. But in this case, it runs into a stop sign that shouldn't be there, a premature stop codon, and essentially the ribosome breaks off, stops doing its job, and you're left with this partially active truncated form, and in other research we know that the mRNA message, that message just kind of disintegrates and is destroyed by the cell since it doesn't encode a full-length protein. So those are two problems that need to be addressed by this strategy of translational read-through to try and get those stop codons to be ignored. Well, we now know from work by PTC, but also work in the laboratory by a number of groups, including our own, that this process can be ignored. And what this would look like here, again, is the ribosome, we'll see, reaches the stop codon, and instead of breaking off, just slows down until a drug can come, bind the ribosome, and cause that stop sign to be ignored, and then translation to continue to ensue and make full-length proteins. So we'll see that in this video here. Again, you can see the translation process happening. A drug hits at the place of the stop codon that allows that process to be ignored, and now a full-length protein is made to do its job. And in addition, we think that process could even stabilize those transcripts to allow more and more translation to occur. Stabilize that message to allow more and more protein to be made and benefit to be conferred. So because premature stop codons are about 10% of CFTR mutations, that's another approach that could add a group of 10% of individuals. And this is work in our lab that shows this is indeed possible. We're using agents that are derivatives of a common antibiotic, gentamicin, that is known to cause a read-through at very, very low levels. And we've been able to optimize those drugs to improve the level of read-through. And we're getting to a point where it's close to being enough that we could expect it could make a difference for CF patients. And in addition, we know that we can perhaps, even if it's not enough, but it's some, we could use a potentiator to step on the accelerator of those channels as well and further accelerate that. And so that's research that's in the laboratory at present, but attempting to be advanced to individuals. I'm going to spend the rest of my time talking about approaches for the most common CFTR mutation and return to the F508 deletion mutation and look at correctors that try to improve the folding of CFTR. And this includes the agent, the VX809. Well, the correction of F508 is a very important target, but it's also a challenging one because it exhibits multiple problems. It has impaired cellular processing, which means it's recognized as misfolded and removed before it ever reaches its active site at the plasma membrane. Even when some escapes that process, we have a quality control process that removes those proteins, but sometimes a little bit of F508 protein escapes and makes it to the surface. But the material that does make it through there doesn't gate normally either. So it's almost a mix of two problems. And then yet another problem that it has is when it makes it to the surface, if it's misfolded, the cell also patrols proteins that are misfolded that are at the cell surface and will remove misfolded protein from the surface. So we call that half-life when it doesn't live, that it has a shortened half-life when it doesn't live at the cell surface for very long. So now we're going to see a video, returning back to one of the first videos that I showed, of what it might look like in the cell when this processing defect is present. And what we'll see here is a CFTR is made, it's inserted into the membrane, but it looks different than the CFTRs you've seen before in that it's bigger and misfolded and globular. And therefore, it's going to be removed from the membrane before it ever migrates to the surface. Even when it does migrate to the surface, it's not going to have the function that we expect it to have, like a normal channel would. So here's that ribosome again, and it's inserting the CFTR into the membrane. And when it completes its job, you can see that it's misfolded, and they're in color encoded here as black because they're bigger than normal and more misfolded, and they don't go very efficiently into these vesicles. And occasionally a channel will escape, and make it to the surface, but the density of those channels, or the number of those channels at their surface, is very low. And you can see that bottom of that channel is misfolded because the area that controls its gating is not working well, and therefore it doesn't move very much chloride or bicarbonate. And that's what we envision patients with the F508 mutation suffer because of that deletion in their protein. Well, what would this look like in the era of a two-drug treatment that would use drugs to correct this process? One would be a corrector to cause it to fold up more normally and replace the missing phenylalanine, the interactions that phenylalanine normally does, to allow that protein to fold up more normally, and then allow essentially at least some channels to reach the surface. And then you're going to see a second drug, such as resembled by the potentiator, ivacaftor or VX770, to then step on the gas on those now appropriately folded channels, but are relatively few in number because none of these drugs are even close to perfect. So let's take a look at that process. So here's a channel, but at the time of the folding, that drug binds and then allows that CFTR channel to become a more tight structure, a more folded structure. And now you can see these yellow channels achieving to the membrane. And therefore, even though they're not quite as the number that we saw in the normal situation, they do migrate in greater number to the surface, insert into the plasma membrane, and serve there to function better, but perhaps not well enough. And so then you can step on the gas of gating and then get those channels to work even better. And that's, again, the vision of what two-drug therapy could look like, where a corrector is combined with a potentiator. So this is some of the science that drove the fact that this could, in fact, work in people. You can see that the CFTR function is shown on the y-axis, and the more drug of this corrector you give as we move from left to right, you can see those orange balls move further up the y-axis as CFTR function is improved by the more corrector that you give, or in this case, the more VX809 that you give. And then in this data, again generated by Vertex, when you add ivacaftor to that, you essentially step on the gas, double its activity, and the more activity you had to begin with, then the more activity that you have at the end. And at the end of the day, you can see on this scale, that was about 30% of CFTR function, which we talked about when we think about G551D patients, might be enough to improve lung function. Because again, we're in that zone where we expect that could result in clinical improvement. Well, there have been results of early testing, certainly not like the phase 3 testing we've talked about with other treatments, but in phase 2 testing, which is a relatively small number of patients, we've seen evidence that this seems to be working. In this study, first the corrector VX809 was given, and that's what you see in yellow in the monotherapy part of this plot. And then on top of that, ivacaftor or VX770 was added to those patients. And that's what you're going to see in the combination therapy zone of the plot that's shown in green. And what we're plotting is lung function over the course of this 2-month study. That's why it's 56 days long. What happened when you got placebo is that really not much. There was certainly no improvement in lung function. If anything, it was drifting down just slightly during the study. And that continued when the patients continued to get a placebo pill or a sugar pill instead of the drug. In the patients that get the highest dose of the corrector, VX809, you can see that there was really no improvement either when that drug was given alone. But then when ivacaftor was added to potentiate the channels, to step on the gas, that's where this improvement in lung function was observed. So at the end of the day, there's about a 6% difference from those individuals that received placebo. And the hope is that should be enough, especially when the two drugs are given together for the duration, and for a long period of time, that could make meaningful improvements in patients with two copies or homozygous for the F508 mutation. And that Vertex just announced in the last week that strategy is now going to be tested in phase 3 testing in really large studies that involve maybe 1,000 CF patients across the world to try and test this for a long period of time. These are other results that show that the patients that receive drug, shown in blue, compared to the patients that receive sugar pill, shown in yellow, with one drug really don't have much of a benefit. But when the combination of the two is given, which you can see as the bar graphs in blue shift over to the left, and more patients, each bar graph represents a single patient, has improvement in their lung function, with some having really big improvements. You can see some are up there in the 20%. Many are lower than that. But at the end of the day, you can see that if you look at, say, a 10% improvement in FEV1 or a 5% improvement in FEV1, there's getting to be a substantive number of individuals that are having the benefit. So that's, again, another piece of evidence from the studies that suggest that the strategy is certainly worth further pursuit and testing in longer-term trials. So again, based on that, Vertex will do a phase 3 trial that looks at the combination of 809 and 770, or ivacaftor, in patients who have two copies of the F508 mutation. And the results could, again, make another big jump in the number of patients that have an effective CFTR drug. And further studies are planned to test the effect of these type of combinations in patients with only one copy of the F508 mutation. But further results are being forthcoming, and those are simply in the planning phases. And there are other corrector and potentiator combinations being tested even now. One of them is called VX661, but there are a number of others that are coming online. So I hope I've given you a sense for where the field presently stands, and even announcements that have made in the last week to try and advance CFTR drugs for a much greater number of patients with various CFTR mutations. But what I want to do now is, just in the last few minutes of the talk, is give you a flavor for some of the science that's going on that is attempting to solve the F508 problem by many groups, including both commercial groups as well as academic laboratories, to solve the F508 problem. So what we've shown is that although there's plenty of reason to be hopeful, in the laboratory, even the best drugs only improve trafficking somewhat. And the correction part of that effect is only minimally active with single agents, modestly active with single agents. And the next challenge is to develop a corrector and potentiator combinations that achieve essentially normal levels of function that we would hope would help people for even earlier in the disease process or into an even greater extent. And new discoveries are now pinpointing the problems in processing and the problems in the F508 protein that are going to enable those type of discoveries to commence. Here's evidence showing that when you use one agent, shown in either the blue or the red, you only get some CFTR function. But when you can combine those drugs together, you can see an effect that's called synergy, or where those effects are more than additive. And you get these large improvements in CFTR function when you use two drugs together. None of these are the potentiators. All of these are agents that are trying to correct the folding of CFTR. And that points to the fact that there's maybe more than one step that causes a CFTR protein to fold up correctly. And therefore, drugs are going to be needed to address each one of those steps, or perhaps more than one of those steps, to really make a difference. Well, we know, I think I've given you some introduction to the CFTR structure, and we can break out the CFTR structure into its major parts. In this case, again, the top part, shown in the blue and the red, are the part that makes the channel. And in green and orange, you can see the parts that form the gate or do the machinery of the gating. And it turns out that the F508 mutation is shown with that arrow that says phenylalanine or PHE 508. and it's right in an important junction between where the gating machine works and the pore that energy is conferred to open and close that pore. Well, the other problem that I've shown you is that the F508 protein generates this unfolded protein, especially in one of those green and orange areas, in this case in NBD1, what's shown as NBD1 or nucleotide binding domain 1, a big part of the engine of gating. And when that NBD1 is folded correctly, it looks like on the left side of the screen, a nice tight structure. But when the CFTR protein is not folded, it's a very loose, molten structure. And it melts easier. And what we know is that if we can get that structure to form that tighter, more folded structure, we could change its melting point in the lab. So there are groups that are working with pure CFTR to try and change its melting point to address that folding problem of the nucleotide binding domain 1. And in addition, there are people that are using strategies to improve the way the gate engine communicates with the pore, to improve the interaction between those two, because as you see, phenylalanine 508 sits right in the junction between those two places. And so there are drugs that are intended to target the interactions between those two important parts of the CFTR molecule. And this data shows that if you improve the folding, shown on the far left, you get the red line, which is a modest improvement in the amount of CFTR that reaches the cell surface, but clearly not what we'd like to see in normal, which you see in the green line. If you improve the interaction between those domains, you're in the middle curve, and you get what's shown in the blue line, which is a very small effect. But if you do both problems, you get what's shown on the green line. And so that really explains why this synergy has been observed when you use more than one strategy. And it also gives us a much clearer understanding about what needs to be done in the lab to improve the processing of CFTR to get the green line and hopefully land us on the far right end of that green line where you see WT, or the wild type channel, or the norm. That's also another name for the normal channel. So here's I think one of my last videos that kind of wraps this up. Here we can see CFTR again inserting into the membrane. If we can get the situation to be normal, we get this tightly folded structure. Here you can see the green, the purple and the blue nucleotide binding domains becoming their tight structure because the process is normal. The CFTR channel then finishes off its processing, and then all that material comes together in a tightly bound structure because those interactions are present and operating normally and forming the channel that you and I have that are normal functions normally. Because of the science, because of proof of concept in the clinic, and because of these new advances in science, we see now that there are many partners in the pharmaceutical industry that are pursuing drugs that affix these problems. And this is just a list of some, and you can see the various different strategies listed. I'm not going to read them all, just to remind you that there are many different strategies to address each of these problems in the laboratory, and many are being advanced. So I'm going to have a summary slide of CFTR modulators and one vision for the future, and how we've gone from discovery to proof of concept to clinical approval and wide use in a very select population. But studies are already underway that could bring the first drug, ivacaftor, to treat a variety of individuals with responsive CFTR mutations. And the next efforts will evaluate CFTR modulators in individuals with the most common CFTR mutations, including trials that have just been announced. And success has brought additional interest in the approach, including corrector discovery programs by N30, Pfizer, and Genzyme, among others, and you saw a number of others listed. So with that, I hope I've given you a picture of how we can get more and more patients on effective CFTR drugs. And then with the advancement of additional scientific advances that improve the efficacy of these agents even further, how we could then ultimately accomplish our goal to having CFTR drugs for all patients in the CF community. And then finally, how smarter, more focused, and more targeted science is enabling us to accomplish this vision. So I know this talk and this journey hasn't been as straightforward as the road shown here, but hopefully I also haven't left you with a street sign that looks like this. And while we know the road is certainly not going to be smooth, and there are going to be bumps in that road marked by successes and failures both in the clinic and the lab, we're hopeful that the road won't look like this. And so with that, I'm going to thank you for your attention.
Thanks, Steve. That was a tremendous talk. We have 5 minutes or so for questions. Dr. Rowe has a plane to catch. As I said, he was kind enough to make a little dent on his busy agenda to come and be with us. So. And we have questions from the web also.
So I have the questions from the web. So Laura, a 48-year-old with CF, is wondering, on one of the graphs it showed that normal folks with 100% CFTR function and carriers have 80% function. Does that mean that carriers are symptomatic if they have 80% CFTR?
It's a good question. We're quite sure that carriers don't really have symptoms of CF or manifestations of the disease. And that question points out that once you get over 50, 60, 70% function, you're pretty much normal. And so we don't have to be perfect, but the further we get to that number, the closer we get to 100%, the better the drug should work in the long term.
Okay, and sorry, if you guys are going to ask questions, you need to go to mics, and that'll help everybody that's on WebEx as well hear your questions. So another question, why does he, Dr. Rowe, call severe CF pancreatic insufficient? I have pancreatic insufficiency, but I have mild CF.
So those groups that we've categorized is a very imprecise. And it's only by studying hundreds of patients that you can start to categorize those groups. We know that there's patients who have very mild CF, and we don't fully understand the reasons for that, but CFTR doesn't work in many of their organs, including their pancreas, like this individual that asked the question. But if you look at groups on average, we know on average, again, while there's certainly exceptions, that patients who have pancreatic sufficient CF in general live a bit longer and have a less severe course than the average patient with pancreatic insufficiency. But it's only one component of the great degree of variability among individuals.
Hi, I'm a parent of a child with CF, and I'm wondering what CFTR is.
CFTR is the protein that's caused by the CF gene mutation. And it's the channel that we've talked about that functions to move chloride and bicarbonate.
Hello. You mentioned briefly Adalurin and PTC. Can you give us some information about what the current activity is with the studies on Adalurin?
Right now, it's an open label phase after finishing a very large phase 3 trial. A trend towards improvement in lung function was seen in some individuals, and that was clear in a group of people that were not taking aminoglycosides, which we now know in the laboratory interact with PTC124. And so right now there's ongoing dialogue with the regulatory authorities, such as the EMEA, and that's the European counterpart to the FDA, with the company to try and figure out what needs to be done next to try and advance that therapy. And we're waiting on news in that regard.
I would like to know what methods are used to measure improvement. And also, when we get to phase 3, how far are we from the drugs being available to patients?
improvement in people?
Yeah, the ones that are already being trialed, you say there is 20% of 50%
There's a number of,
improvement. So what methods are being used?
Yeah, very good. So there's a number of ways you can try and measure how a patient's doing. The one that's used most commonly in the largest extensive trials is lung function, but spirometry, who, if you're 6 or older, generally you do almost every time you see the physician, and we often use as a blood pressure, if you will, for patients with CF. That's going to be one marker. But the other markers for the CFTR drugs that have been used is sweat chloride. Some of the smaller studies use a test called nasal potential difference. You can actually get CFTR function from the intestine. So some people have their intestinal function measured. And there are other kind of intermediate markers that try and connect what's happening with the protein, CFTR, to what's happening to lung function. And those are things such as what Stanford's been key in advancing, called a measurement called lung clearance index. And others have been using a measure called mucociliary clearance, which measures how well particles move out of your chest, like we've kind of talked about today, but haven't really shown results from. That's often used. All the stuff that I've talked about is generally for smaller studies when people are trying to really understand how a molecule works. And then when you're ready to enroll hundreds or thousands of patients, you try and simplify the study so it can go as fast and as easily as possible.
For people with severe CF, or say, lung function lower than 40 or 50%, what kind of evidence is there that there can be either reversal or stabilization of the damage once they've, started ivacaftor or some of these other treatments?
Yeah. Of course, the ideal situation is that drugs are given before any permanent lung damage could ensue, and I think that's say a 10 or 20-year goal for these type of drugs. But right now, what we know is that many of these drugs have been tested, including ivacaftor, in patients who have at least moderately severe disease. And for instance, in the phase 3 study, even patients that are at the lower end of lung function, around 40 or 50%, had as good of improvement as those individuals with higher ends of lung function. So we think that there's good reason to believe that even when moderate problems are present with the lung, that these drugs should be able to help you. In the most very severe form, we really don't have enough knowledge to know do they work quite as well, equally as well, or perhaps not as well because some of the injury is permanent. It's a big reason that we use in our clinic to remind people to do their very best with the therapies that are available, because as these new treatments come online, we think that they'll do a great job of keeping a lung that's not as injured healthy over the long term.
Hi. In that phase 3 study that we're entering now with the VX-809 plus ivacaftor, do we know how long that study is planned for and when we might hear results?
The trial design hasn't been announced, but generally trials that seek approval are 6 months to a year long, and if that turns out to be the case, and then what we can imagine is it will take a couple years for that kind of study to get done, and then the results to be analyzed and then discussed with the FDA so it becomes available.